Welcome. Sorry for the technical difficulties. Welcome to this morning's discussion. Our discussion on Psyfeld this morning will be on the subway. Any ideas, any thoughts on which character you would like to start with? So I will open this up to all of the undergraduate students as well. So you guys are free. I know that we usually wait about 15 or 20 minutes, but if you would prefer to unmute, you are more than welcome to enter your opinion, any particular character in the episode, The Subway, you would like to discuss.
Panic disorder, sorry.
All right, so yeah, I think Elaine's character in this particular episode, and we're looking at her, what I think clinically would be referred to as physiologic reactivity. The question the clinician has to address is severalfold. Number one is, or are the signs and symptoms clinically significant? Certainly, if they're recurrent and clinically significant, we might be dealing with a mental disorder, the greater likelihood than if this was an isolated event and or if it did not impair functioning. So assuming that it does impair functioning and therefore requires a case formulation, we have to decide whether or not the panic in and of itself is diagnostic or if it's contained within a larger disorder. And this is where the evaluation of anxiety gets tricky. If Elaine is experiencing a recurrent and significant panic-like symptoms that are episodic, the most likely diagnosis is going to be panic disorder. The word disorder will be used here to reflect that there is some significant impairment in functioning. But one example of that will be a clinical term called agoraphobia. We had addressed this before. Does anybody recall what agoraphobia means? Or how it manifests? What is agoraphobia? Just realized I asked two separate questions there. Literally, yeah, I'm sorry, go ahead.
I know it's the fear of having a panic attack, but typically it manifests as people not leaving their house.
Good, that's exactly right. So in individuals with agoraphobia, they have a behavioral change specific that they avoid social situations, right? And that usually manifests as they're not wanting or not being able to leave their home. The reason why is something you also alluded to. It's because of the fear of becoming symptomatic. And in this case, it's due to panic symptoms, these episodic bursts of physiologic hyperactivity, panic, that would be distressing if out in public, whether a restaurant, whether public transportation. So that fear of becoming symptomatic is what defines agoraphobia itself, an anxiety disorder, as well as a qualifier. That is, it's an example of clinical significance within a separate anxiety disorder, in this case, panic disorder. So that might be what's going on with Elaine. The difficulty here is that in cheating and watching 9 full seasons of the situational comedy, I'm not sure if this is recurrent, which means that she may have had a panic attack, but she might not rise to the level, that diagnostic threshold of panic disorder per se. The other clinical question we have to ask ourselves is, well, whether we call it a panic attack or whether we think it's a larger disorder, in either case, might it be in the context of a broader or larger mental disorder? And that's where we get into the terminology of physiologic reactivity. That is she reacting to something, specifically a cue, maybe the subway itself. if that is the case, we have to decide why the subway is precipitating that behavior. It might be because it is a specific phobia, and Elaine has an unreasonable or irrational fear of subways or perhaps even closed spaces in general. Or it may be due to a past trauma, perhaps related to a subway. And in this case, the most likely diagnosis would be either acute stress disorder or post-traumatic stress disorder, depending on the duration of symptoms. So I think with regard to what we see in terms of Elaine's behavior, and I still have one more that I want to discuss, but at this point, we're thinking along the lines of panic attack, rule out panic disorder, but cannot rule out that her symptoms are in the context of a broader disorder. Rule out post-traumatic stress disorder versus acute stress disorder, depending on the duration of symptoms. I'm going to pause for just a second. Any thoughts or any questions with regard to our proposed differential for Elaine's behavior? So with regard to the precipitant being the subway, and therefore creating a differential that not only includes ASD and PTSD, but maybe a specific phobia as well. Is there another cue that you may have picked up on other than the subway itself?
She was around a lot of people.
Right. And remember, as we hear her thoughts, and here as a clinician, as a viewer, we have to decide whether or not Larry David is giving us insight into her thoughts, or if more concretely, we're going to interpret that as Elaine hearing voices. That's something we have to consider as well. But if we leave that in the back burner for just a second, with regard to what we do hear her think, is there anything about being in that enclosed space? What happens to her? There is a dialogue at some point where she asks, "Is someone touching me?" And that has to be considered to be a cue that perhaps it's not the subway itself, and perhaps it's not the enclosed space itself, but it's the fact that she is rubbing up against someone, or vice versa. And from her perspective, that can absolutely be a cue, or if not a cue that precipitates a flashback within the context of either acute stress disorder or post-traumatic stress disorder, maybe just a very normal response or reaction to an extraordinary stressor with someone actually rubbing up against her. That's from Elaine's perspective. From the non-Elaine perspective, with regard to the passenger or passengers around her, what might be in their differential diagnosis? What's the mental disorder referred to when an individual derives sexual gratification from rubbing up against an unsuspecting adult?
Would it be exhibitionist?
Close. So you're definitely in the right category of the sexual deviancies, otherwise referred to as the paraphilias.
Oh, would it be Frotteurism?
That's it. That's it. Frotteurism. And if clinically significant, Frotteuristic disorder. Right. So Frotteurism is going to describe an abnormal behavior that is out of context with regard to a culturally sanctioned norm. However, when that behavior or when that abnormal behavior is clinically significant, Frotteurism actually evolves to the clinical diagnosis of Frotteuristic disorder. And that transition was something that the DSM-5 really specified as of 2013. All right. Any other observations with regard to Elaine? It's a lot there. And again, I really want to emphasize the clinical pearl of how difficult this was in terms of somebody coming in with what looked like panic, but now we have several diagnoses, even from Elaine and the Elaine-only perspective, across multiple illnesses within the anxiety disorder spectrum. Very difficult to actually get at a single best diagnosis of an anxiety disorder because there are so many overlapping signs and symptoms, including physiologic reactivity. Any other characters catch your eye that you want to discuss this morning? What's going on with Kramer? Could somebody identify the subway stop he gets off?
I'm not entirely sure. I know his motivation is to get the money to pay for all his tickets, and I think he stops at was it a horse racing kind of kind of thing?
Yep, it's called off-track betting. It allows you to bet on horse races and not be at the track. Again, for those of you who have watched or are familiar with the situational comedy, Kramer has a quote-unquote gambling problem. And you have to remind me if it's in this episode because it can certainly be contained in another episode. He actually asks somebody to put a bet in for him because he's got a problem and that he doesn't want to do it himself because of his addiction. So he actually asks somebody else to put the bet in for him, somehow addressing the problem, and therefore, because there's one degree of freedom, demonstrating that he's not actually performing the addictive behavior if somebody does it for him. So gambling disorder is the most likely diagnosis here, and we'll discuss that in a little bit more detail around noon or 12:30 today. Right? But certainly, gambling disorder really needs to be on our differential diagnosis. Having said that, the other thing about Kramer, and again, this is a stretch from the current episode of the subway, we do see him become addicted to other things as well. We know that in other episodes, he becomes addicted to caffeine, he becomes addicted to nicotine, and he even becomes addicted with regard to voyeurism, and he can't stop his behavior. Now, sex disorder is not a diagnosis. It's certainly something that the American Psychiatric Association is considering for publication, but as of 2020, it is not yet the diagnosis in the DSM. But Kramer does demonstrate that as well. And then there's, whether it's metaphorical or whether there's something to it, he becomes addicted to, of all things, Kenny Rogers fried chicken or rotisserie chicken. Again, what that might serve as a metaphor is up in the air. Again, separate episode, but yet another episode that identifies addictive behavior in this character. So it's something to watch out for. In this particular episode, it's gambling disorder. That is a DSM diagnosis, and it's one we'll discuss in more detail around noon today. How about Jerry? Where does Jerry or George get off? What stops? Or at least describe their behavior when they get off the subway.
Jerry gets off of Coney Island, I believe.
Yeah.
The only significant thing that I recognized was his friend that he made on the subway, who was completely naked. So I guess I could see that being as part of like a sexual deviance disorder. I guess more towards exhibitionist.
Yep. Yeah. If he were approached by Port Authority, the likelihood is that he would have received an emergent psychiatric evaluation. And during that psych eval, the clinician would have to inquire what motivated his behavior. And if it is determined that at the root of the behavior was sexual gratification, then yes, exhibitionism describes the behavior. And if it leads to clinically significant impairment in functioning, then exhibitionist disorder is the single best diagnosis. Yeah, I agree. Now, there are a couple things I want to mention about Jerry. One, the first one is very brief because we will return to this topic again around noon when we discuss The Nightmare Before Christmas. But getting off the stop at Coney Island is significant. That is, there is a link between Coney Island and the theme of this particular episode, the subway. So I'm gonna just leave it there. If between now and noon you want to look into this, there is an established link between Coney Island, not necessarily dialogue pertaining to Coney Island and the script of the subway per se, but definitely Coney Island links to the theme of addiction with regard to this episode, the subway. The second point I want to make is the way Jerry is introduced to the naked man. Anybody recall how Jerry actually first sees him naked?
He wakes up. I wanted to talk about that as well. I know it probably doesn't reach clinical significance, but how he initially fell asleep, it kind of reminded me of narcolepsy, except because of the muscle paralysis that he kind of had when he was like slumped over in the chair. But I mean, in previous episodes, I've never seen him do that before, so I'm not sure that would be relevant.
Actually, I think it is. There's a couple of things to look at here. Number one, Jerry falls asleep. What I think is going on with regard to Jerry falling asleep on the subway is that he is actually demonstrating a condition called excessive daytime sleepiness, where individuals fall asleep during low stimulus situations. And he's just sitting there in the subway, stop after stop, and boom, he falls asleep. Excessive daytime sleepiness is differentiated from fatigue or lethargy from the fact or by the fact that individuals, if given the opportunity, can and often do fall asleep. An individual who's tired or lethargic might report their energy level, but they're not falling asleep. So that's usually the way to differentiate an individual who's lethargic or fatigued versus one who is demonstrating excessive daytime sleepiness, or EDS. Now, EDS may actually be a criterion for a larger disorder, usually a sleep-wake disorder. And there's many of them, but certainly two that commonly appear on exams include narcolepsy as well as obstructive sleep apnea. Interestingly, while the naked man demonstrates the prototypical morphotype with regard to OSA, obstructive sleep apnea, Jerry Seinfeld does not. Individuals with OSA, at least on tests, but certainly reflected in clinical medicine, are often middle-aged men who are obese or extremely obese, right? So obesity, body mass index 30 or greater, extreme obesity 35 or greater, with a large neck. And we actually have a bedside maneuver, physical exam maneuver, if you will, called the adjusted neck circumference, where you actually measure someone's neck in centimeters, and then you add, I believe, 3 points if they snore, and 4 points, 4 extra centimeters, if they gasp. And you come up with an actual total neck circumference. And there are cutoffs with regard to when the individual clinician should be referring the patient to a sleep study, a polysomnography, to rule out OSA. High likelihood with regard to diagnostic yield of that polysomnography in the naked man. Low likelihood in Jerry Seinfeld. Now, there are conditions that are of maxillofacial, redundant oropharynx that can block the airway even in individuals who are not obese. So definitely needs an ENT exam to make sure that there's nothing going on oropharyngally. But otherwise, those other risk factors that we often look at for OSA, extreme obesity, large neck, and an elevated, adjusted neck circumference are simply absent in the character of Jerry Seinfeld. The other condition is narcolepsy. And Jerry demonstrating EDS, excessive daytime sleepiness, is consistent with narcolepsy. Now, there are a couple other things Jerry demonstrates that further support this diagnosis. Number one, remember that he's first introduced to the naked man upon awakening, right? So, in a way, and the way Larry David produces this scene, it becomes wavy as if it's a dream sequence. So we have to wonder whether or not Jerry is dreaming or perhaps even seeing things upon awakening. Any thoughts about what that is called when individuals have visual hallucinations upon awakening? Because this scene certainly is reminiscent of that. Again, the clinical label of visual hallucinations upon awakening is called hypnopompic hallucinations. Again, very commonly comes up on exams, very commonly comes up on exam questions pertaining to narcolepsy. Hypnopompic hallucinations are visual hallucinations upon awakening. They are differentiated from hypnagogic hallucinations, that is visual hallucinations upon falling asleep, which is not the case in that scene on the subway. The final thing that Jerry tells us at the very end of this episode is that he passed out on the cyclone. Now, again, people can do that in a vacuum. Certainly they can vasovagal. They can become excited and pass out. That can and perhaps often does happen on awesome roller coasters. But taken in proper context with hypnopompic hallucinations and excessive daytime sleepiness in Jerry is consistent with narcolepsy, because that is the drop attack, right? That is the drop attack, which, unlike EDS, often occurs in high stimulus situations, such as riding the cyclone in Coney Island, right? So very interesting with regard to Jerry demonstrating three features of narcolepsy. In the remaining 4 minutes, I just want to review narcolepsy real fast. Again, it is a sleep-wake disorder. It is referred to as a parasomnia. That is, it's an abnormal behavior at or around the time of sleep, parasomnia, which differentiates from another subset of sleep-wake disorders called dysomnias, which get at irregularities of sleep. Actually, I take it back. I believe narcolepsy is a dysomnia because of the fact that it is a dyssynchrony with regard to sleep architecture. Specifically, what happens in narcolepsy is that the individual will REM during non-REM periods, right? So your sleep from 11 to 8 a.m. Goes through different cycles of REM and non-REM. The first cycle, of course, is non-REM, followed by REM, etc. The greater part of REM, 2/3 of which come in the latter half of the night. Opposite is true for non-REM. If these cycles break down and you have bursts or episodes of REM during non-REM periods, you likely have narcolepsy. And if your burst of REM occurs during a non-REM period where you are awake and alert, you are likely to present to clinical attention, because an individual who is at the theta stage of sleep, theta waves are waves that are twilight, that is, you're right at that sleep-wake interface. If you are in theta, if you are in that twilight aspect or state of sleep, and you begin to REM, you will begin to dream, and you will have muscle paralysis, and you will have a drop attack. That is, dreaming, visual hallucinations, muscle paralysis, drop attack are those diagnostic criteria for narcolepsy. And the physiology or the pathophysiology behind that is simply having those characteristics of REM present during periods where you are more awake and alert, i.e. non-REM. Non-REM also includes states of wakefulness, like right now. If right now you had a surge of REM, you would see things because you would actively dream while awake and alert. And you would have muscle paralysis, which is completely normal when you REM. Then muscle paralysis, as you are listening to me, sitting at your desk with your laptop open, will result in a drop attack. Again, diagnostic of narcolepsy. Right? So it's REM intrusion into non-REM states, including states where the individual may be awake and alert, like when riding the cyclone. So that's a quick or ultra quick primer on narcolepsy. In the last minute, just want to review some treatments for narcolepsy. Individuals will often be prescribed a tricyclic antidepressant. These medications have significant anticholinergic side effects, which disrupt REM sleep, for better or for worse. When you have REM intrusion, this is for the better. You want to disrupt that. And by giving a medication with these anticholinergic side effects, like the tricyclic antidepressants, you can disrupt REM, therefore you can disrupt narcolepsy, that REM intrusion. On the other hand, individuals also awaken sleepy and even may demonstrate excessive daytime sleepiness. So in the morning, they're often prescribed a stimulant as well, something like methylphenidate, a stimulant. So a tricyclic or an anticholinergic at night, or a stimulant in the morning. There are other medications other than the tricyclics that are perhaps given as well. We can review those later, either during abnormal activity or our noon conference as well. Before we sign off, any last questions with regard to Seinfeld's The Subway? All right, well, have a great rest of your morning, and we will be back on Periscope 12 or 12:30 today. Watch Twitter for our discussion on The Nightmare Before Christmas. Thank you.